Good evening, Dr. Phil here. Today we'll be discussing on synthetic opioids part 1. Introduction. Synthetic opioids contain the phenanthrene nucleus of morphine. They are manufactured by chemical synthesis rather than modification of morphine. Opioid classification, pharmacokinetics, receptors and pharmacodynamics has been discussed in previous videos. Fentanyl. Fentanyl is a phenylpiperidine. It is the parent compound of Alfentanil and Remifentanil. It is highly lipid-soluble. Preparations includes parenteral, transdermal, and transmucosal preparations. Regarding the transdermal preparation, high potency of fentanyl allows transdermal administration. The patch and the underlying dermis act as the reservoir for fentanyl. Plasma concentrations do not reach steady state until about 15 hours after initial application occurs. After fentanyl patch removal, plasma concentrations also decline slowly with a half-life of 15 to 20 hours. Transmucosal preparations include intranasal, sublingual, lozenges, and mucosal patch. Protein binding. Fentanyl binds to alpha-1 acid glycoprotein and albumin. 40% of the protein-bound fraction is taken up by erythrocytes. Metabolism of fentanyl occurs in the liver and lungs. Fentanyl undergoes N-dealkylation and hydroxylation in the liver. Fentanyl has a high hepatic extraction ratio. Clearance approaches liver blood flow at 1.5 liters per minute. Due to high first-pass metabolism of about 70%, fentanyl is not given orally. The lungs exert a first-pass effect on fentanyl up to 75% of the dose. This first-pass effect buffers the plasma from high peak drug concentrations. Metabolites of fentanyl such as norfentanyl are inactive. Fentanyl accumulates with repeated injections or prolonged infusions. Excretion. 9% of fentanyl metabolites are found in the feces. 70% of fentanyl metabolites are found in the urine at 4 days. The pKa of fentanyl is 8.4. Protein binding is 90%. Octanol water partition coefficient 813. Clearance 10 to 20 mL per kg per minute. Volume of distribution 3 to 5 liters per kg. Terminal half-life 2 to 4 hours. Context-sensitive half-life for a 4-hour infusion is 260 minutes. Duration of action 1 to 1.5 hours for IV injection. Potency. Fentanyl is 80 to 100 times more potent than morphine in the acute setting. It is 30 to 40 times more potent than morphine when given chronically, for example, via slow-release transdermal patches. Onset of action is 1 to 2 minutes with a peak action at 4 to 5 minutes for IV administration. A time lag exists between the peak plasma fentanyl concentration and peak slowing on the EEG. This reflects the effect site equilibration time between blood and the brain for fentanyl, which is 6.4 minutes. Duration of action after a single IV bolus lasts about 30 minutes. Action of fentanyl is terminated by redistribution initially as plasma clearance is less than that for morphine. Terminal half-life is 2 to 4 hours. Some books quote 3.1 to 6.6 hours. All values quoted in this video may vary depending on different sources. Compared to morphine, this longer elimination half-time reflects a larger volume of distribution of fentanyl due to its greater lipid solubility. More rapid passage into highly vascular tissues occur with fentanyl when compared with the less lipid-soluble morphine. 80% or more of injected fentanyl leaves the plasma in 5 minutes. Context-sensitive half-life. After 2 hours of constant infusion, the context-sensitive half-life of fentanyl is 48 minutes. After 8 hours of infusion, the context-sensitive half-life of fentanyl is 282 minutes. This increase in CSHT reflects the return of fentanyl from peripheral compartments to the plasma after saturation of inactive tissue sites with fentanyl during prolonged infusions. The rate of decrease of plasma concentration of fentanyl is slowed after fentanyl infusion is discontinued, as tissue reservoirs of fentanyl replaces fentanyl eliminated by hepatic metabolism. Accumulation of fentanyl. Continuous infusions or repeated doses of fentanyl leads to accumulation in the body as its context-sensitive half-time increases rapidly with the duration of infusion. Variability in plasma concentrations and secondary plasma peaks can occur. This is because fentanyl has a large volume of distribution as it is highly lipid soluble with rapid peripheral tissue uptake limiting initial hepatic metabolism. Clinical uses of fentanyl. For treatment of acute pain, 1 to 2 mcg per kg IV or sublingual lozenges 100 to 800 microgram for short painful procedures such as burns dressing change. Treatment of chronic pain. Transdermal patch at 25, 50, 75 or 100 micrograms per hour placed on chest or upper arm and replaced. Use a different site every 72 hours. Fentanyl absorption depends on skin thickness, subcutaneous fat layer, subcutaneous perfusion, etc. Peak analgesic effect for transdermal patch is reached only after 10 to 12 hours, duration of analgesia 3 to 4 days, sublingual lozenges 100 to 800 mcg for breakthrough pain. Preoperative medication via transmucosal route, co-induction agent during anesthesia, 1 to 3 microgram per kg IV with spontaneous ventilation. If administered 5 minutes before induction of anesthesia, this reduces the requirements for inhalational anesthetics and propofol by about 50%. 5 to 10 mcg per kg with IPPV, up to 100 mcg per kg is used for cardiac surgery. Watch out for muscular rigidity and hypotension. Use lean body weight for obese patients. The next indication is intraoperative analgesia and as an adjuvant to anesthetics to blunt the response to intraoperative pain, such as due to sudden changes in level of surgical stimulation or airway manipulation. Dose ranges 2 to 20 mcg per kg IV. Dose and frequency are dependent on the patient's weight, type of surgery, etc. Fentanyl should be administered 5 to 10 minutes prior to an anticipated painful, stressful event. Fentanyl reduces the doses of anesthetics needed to blunt sympathetic nervous system responses to surgical stimulation. The dose for surgical anesthesia is 50 to 150 mcg per kg IV. Historically, high-dose fentanyl and nitrous oxide were used for analgesia and suppression of consciousness and provided excellent hemodynamic stability. However, this combination could not guarantee amnesia, thus this technique has been replaced with balanced anesthesia or total intravenous anesthesia. Opioids are used with sedatives, intravenous anesthetics, or muscle relaxants to assure amnesia and analgesia. Post-operative analgesia can be provided via transdermal patch. Patient control analgesia. The dose is 20 to 100 mcg boluses with 3 to 5 minute lockout. An experimental transdermal patch employing iontophoresis has been developed for post-operative patient control analgesia. Iontophoresis is a technique of introducing ionic medicinal compounds into the body through the skin by applying a local electric current. Sedation. As an infusion in critical care, the dose is 1 to 5 mcg per kg per hour. Synergistic actions occur during co-administration of fentanyl and benzodiazepines. Hypnosis and depression of ventilation are potentiated. Analgesia for early labor, 25 mcg intrathecally. Adverse effects of fentanyl resembles that caused by morphine. Unlike morphine, fentanyl does not cause histamine release. Bradycardia or hypotension is more prominent with large doses of fentanyl than morphine. Muscle rigidity may occur. Post-operative respiratory depression can occur if large doses of fentanyl are used, especially when opioid pre-medication and other depressant drugs are co-administered. Fentanyl administered to head injury patients may cause modest increases in ICP despite unchanged PaCO2. Increase in ICP may range 6 to 9 mmHg. Sufentanil. This is a phenol analog of fentanyl, introduced in 1984. It is available in the USA but not the UK for marketing reasons. Preparations include IV, sublingual, intrathecal, and epidural. It is metabolized rapidly by N-dealkylation in the liver. Sufentanil has a high hepatic extraction ratio. Clearance is 0.9 liters per minute. Active metabolite. Desmethylsufentanil is active at the MOP receptor with 10% of sufentanil's potency. This metabolite is produced in minor quantities and has no clinical significance. Excretion is renal. pKa is 8.0, protein binding 93%. Octanol water partition coefficient is 1778. Clearance of Sufentanil is 10 to 15 mL per kg per minute. Volume of distribution is 2.5 to 3 liters per kg. Terminal half-life 2 to 3.5 hours. Contact-sensitive half-life for a 4-hour infusion, 30 minutes. Duration of action 0.8 to 1.3 hours. Sufentanil is one of the most potent opioids. It is 625 times more potent than morphine, 12 times more potent than fentanyl. Sufentanil has very low levels of non-specific binding that may increase potential effect site concentrations. Onset of action. Effect site equilibration time of Sufentanil is 6.2 minutes and is similar to fentanyl, 6.8 minutes. Sufentanil's lipophilicity is 2 times greater than that of fentanyl. This high lipid solubility allows rapid penetration of the blood-brain barrier and onset of CNS effects. Peak analgesic effect of Sufentanil occurs at about 8 minutes after intravenous administration. After a large dose, the speed of onset is caused by saturation of receptors and non-specific sites, resulting in the potential for overdose. Duration of action for IV route is 0.8 to 1.3 hours. Small doses results in rapid redistribution to inactive tissue sites, which terminates the effect. A cumulative drug effect can accompany large or repeated doses of Sufentanil. Terminal half-life 2 to 3.5 hours as mentioned. Context-sensitive half-life is 30 minutes after a 4-hour infusion. The reduction in the plasma Sufentanil concentration after termination of its infusion is accelerated by metabolism and continued redistribution of Sufentanil into peripheral tissue compartments. Sufentanil compared to Alfentanil. Although Sufentanil is highly lipid soluble, diffusion to tissues is slower than Alfentanil because Sufentanil is highly protein bound, resulting in low unbound plasma fractions at body pH. Elimination half-life of Sufentanil 2 to 3.5 hours is intermediate between that of fentanyl 2 to 4 hours and Alfentanil 1 to 2 hours. Contact-sensitive half-time of Sufentanil is less than that for Alfentanil for continuous infusions up to 8 hours. Thus, Sufentanil may have a more favorable recovery profile when used over a longer period of time. Compared to Sufentanil, Alfentanil is more efficacious in the treatment of discrete and transient noxious stimuli due to its short effect site equilibration time, 1.4 minutes versus 6.2 minutes, which allows rapid access of the drug to the brain and facilitates titration. Clinical uses of Sufentanil. As an analgesic during anesthesia, Sufentanil demonstrates cardiovascular stability and lack of histamine release. Compared with fentanyl using a comparable dose, Sufentanil produces a longer period of analgesia and less depression of ventilation. Compared with large doses of morphine or fentanyl, Sufentanil results in more rapid induction of anesthesia, earlier emergence from anesthesia and earlier tracheal extubation. Typical Sufentanil dosages are 0.1 to 0.5 mcg per kg for minor surgery, up to 8 mcg per kg for longer procedures, up to 30 mcg per kg as the sole agent for cardiac surgery. Epidural dose 10 to 75 mcg, spinal dose 5 to 20 mcg, effects last 2 to 6 hours for spinal dose. For post-operative analgesia, sublingual Sufentanil PCA system for post-operative pain relief has been introduced. Sufentanil has a high therapeutic index compared to other opioids. Alfentanil. This is a phenylpiperidine compound derived from fentanyl, developed in 1976. Routes includes IV and epidural route. Metabolism. Alfentanil is efficiently metabolized by hepatic CYP3A4 or 5 to noralfentanil, which is inactive, and N-phenylpropionamide. Clearance is about 96% from the plasma within 60 minutes of its administration. Clearance is markedly influenced by CYP3A activity. Genetic variability in the activity of CYP3A4 or 5 may result in 2 to 3 times up to 10 times variations in pharmacokinetic values when alfentanil is given by IV infusion. Thus, it is difficult to create reliable infusion regimens to attain and maintain specific plasma concentrations of alfentanil. Excretion is renal. pKa of alfentanil is 6.5, protein binding 91%, octanol water partition coefficient 128, clearance 4 to 9 mL per kg per minute, volume of distribution 0.4 to 1 liter per kg, terminal half-life 1 to 2 hours, contact-sensitive half-life for a 4-hour infusion 60 minutes, duration of action 0.25 to 0.4 hours for IV route. Contact-sensitive half-life is 50 minutes after 2 hours of IVI alfentanil as it accumulates when given by IV infusion. Contact-sensitive half-life of alfentanil is longer than that of sufentanil. Peak plasma levels via IV route occurs 1 minute after IV injection. As the pKa of alfentanil is low, 6.5, alfentanil is largely unionized at plasma pH, allowing rapid diffusion to the effect site and rapid onset of action. Alfentanil has the most rapid onset time of all opioids, although it is less lipid-soluble than some opioids. Duration of action is 0.25 to 0.4 hours as mentioned. Alfentanil does not bind strongly to opioid receptors, and its effect site concentration reduces rapidly as plasma concentrations reduces. Alfentanil is an analog of fentanyl that has a shorter duration of action, 0.25 to 0.4 hours versus 1 to 1.5 hours. Alfentanil is less potent than fentanyl, about 1/5 to 1/10. Alfentanil has more rapid onset of action than fentanyl, 1.4 minutes versus 6.8 minutes. Although alfentanil has a lower lipid solubility, penetration of the blood-brain barrier by alfentanil is rapid because of its large non-ionized fraction at physiologic pH compared with fentanyl, 89% versus 8.5% at pH 7.4. Alfentanil has a shorter half-life than fentanyl, 1 to 2 hours versus 2 to 4 hours, due to its lower volume of distribution in spite of a lower clearance. Uses of alfentanil in anesthesia. Due to alfentanil's rapid onset and offset of intense analgesia, it is used to provide analgesia for transient but painful procedures during anesthesia. For example, 15 mcg per kg IV about 90 seconds before laryngoscopy, tracheal intubation, or performance of a retrobulbar block. Alfentanil has a lower incidence of post-operative nausea and vomiting in outpatients when compared to equipotent doses of fentanyl and sufentanil. Alfentanil has minimal cardiovascular effects, although bradycardia and hypotension can still occur. IV dosage. For spontaneously breathing patients, up to 500 mg initially, followed by increments of 250 mg, slow injection reduces the incidence of apnea. To obtain the hypertensive response to tracheal intubation, 30 to 50 mcg per kg up to 125 mcg per kg is used in cardiac surgery. IV infusions, a loading dose of 50 to 100 mcg per kg, followed by 0.5 to 1 mcg per kg per minute. Higher rates have been used in TIVA. Infusions is discontinued 10 to 30 minutes before surgery ends. For sedation in ICU, the dose is 30 to 60 mcg per kg per hour. Remifentanil. This is a phenylpiperidine ester. It is an ultra-short-acting synthetic MOP receptor agonist. Formulation. Remifentanil is formulated as a lyophilized white crystalline powder containing glycine for IV administration. It should not be administered epidurally or spinally. It is stable for 24 hours after being made up in solution at room temperature. In adults, a 50 mcg per ml solution is recommended by the manufacturer. Metabolism. Remifentanil has a methyl ester side chain, which allows degradation by non-specific plasma and tissue esterases. Other opioids do not have such an ester linkage. Degradation by non-specific plasma and tissue esterases is a non-saturable process, and clearance is significantly greater than hepatic blood flow. This unique metabolism underlies several characteristics of remifentanil, such as its brief action, rapid onset and offset, enabling precise and rapidly titratable effects, lack of accumulation, rapid recovery after discontinuation. The following do not affect remifentanil clearance. Deficiency in plasma cholinesterase and anticholinergic drugs do not affect remifentanil clearance, as remifentanil does not appear to be a substrate for butyryl cholinesterases. Hepatic dysfunction and renal dysfunction do not affect remifentanil clearance as well, as esterase metabolism is usually preserved in these conditions. Metabolites. The principal metabolite of remifentanil is remifentanil acid. It has minimal potency of less than 0.5%. Remifentanil acid is excreted via the kidneys. Remifentanil acid is not thought to be clinically significant even in renal dysfunction. Half-life of remifentanil. 99.8% of remifentanil is eliminated during its distribution half-life 0.9 minutes and elimination half-life 6.3 minutes. Quick degradation by non-specific tissue and plasma esterases gives remifentanil a short and predictable duration of action, which is confirmed by its context-sensitive half-time of 4.5 minutes after 2 hours of infusion and 9 minutes after 8 hours of infusion. In effect, remifentanil can be described as context insensitive. Remifentanil will accumulate less than other opioids due to its small volume of distribution, rapid clearance, and low inter-individual variability. Clearance is 3 to 5 liters per minute, which exceeds liver blood flow, affirming its extrahepatic clearance. Protein binding is 70%. This table compares remifentanil with other opioids in terms of their pharmacokinetic differences. Potency of remifentanil is similar to fentanyl. It is 20 times more potent than alfentanil and 100 to 200 times more potent than morphine. Onset of action. Remifentanil has a rapid blood-brain equilibration time of just 1.1 minutes and is similar to that of alfentanil, 1.4 minutes. A quick onset of action and short half-life makes remifentanil ideally suited for infusions during anesthesia and in the critical care setting. It can be titrated rapidly to achieve the desired effect. Clinical uses of remifentanil. Analgesia during anesthesia. Induction of anesthesia 0.5 to 1 mcg per kg per minute with or without initial bolus of 1 mcg per kg over at least 30 seconds. Watch out for muscle rigidity and bradycardia. For target-controlled infusions, such as using the Minto model, a plasma concentration of 3 to 8 nanograms per ml will usually achieve adequate intraoperative analgesia. Very stimulating procedures may require up to 15 nanograms per ml. During spontaneous ventilation, 0.025 to 0.1 mcg per kg per minute. During intermittent positive pressure ventilation, 0.05 to 2 mcg per kg per minute. Remifentanil displays large variability in its analgesic effects among patients. Remifentanil dosing requires titration to effect. Different surgeries produce differences in nociception and hemodynamic stress responses and requires different dosages to suppress pain and stress. For example, remifentanil plasma concentration causing a 50% probability of no clinical response to stimulation ranges 3.8 nanogram per ml for prostatectomies, 5.6 nanogram per ml for nephrectomies, and 7.5 nanograms per ml for abdominal hysterectomies. Remifentanil causes a reduction in both volatile anesthetic and propofol requirements. Role for remifentanil boluses. Due to remifentanil's rapid pharmacokinetic activity, the need for an initial remifentanil bolus is rather limited. A slow infusion given in 1 to 2 minutes of 0.5 to 1 mcg per kg can be used if a bolus is required. MAC reduction observed with remifentanil use and its very short context-sensitive half-time make rapid awakening possible at the end of surgery. Post-operative pain scores are higher after a remifentanil-based anesthesia, and requirements for morphine are increased. Administer morphine 30 to 45 minutes before the end of surgery, some books quote 60 minutes, or a single fentanyl bolus of 50 mcg or ketamine 0.125 mg per kg at the end of surgery. Kindly refer to the section on opioid-induced hyperalgesia in the video on opioid pharmacodynamics for further details. Sedation and analgesia in healthy adult patients. For example, remifentanil 0.05 to 0.1 mcg per kg per minute in combination with midazolam 2 mg IV. This requires adequate monitoring and skilled personnel to detect and manage an adverse respiratory event. Due to remifentanil's rapid onset, there is no delay between increasing remifentanil plasma concentration and depression of ventilation, and there is a short delay between changes in the plasma concentration and the end-tidal CO2. Remifentanil has been used in patient-controlled analgesia during labor. A typical regimen would be 20 to 40 mcg bolus with a 2-minute lockup. Remifentanil is not recommended for epidural or spinal use, since the formulation contains glycine. Reduction in dosage is required in hepatic disease, hemorrhage, and shock due to increased opioid sensitivity. Disadvantages of Remifentanil. Remifentanil has a very rapid offset of action. Breakthrough pain can occur very soon after discontinuing Remifentanil infusions unless alternative analgesia has been given before Remifentanil discontinuation. The offset of effect is caused by metabolism rather than redistribution, evidenced by its high clearance and low volume of distribution. This makes Remifentanil unsuitable for patient-controlled analgesia for post-operative pain. However, there are some obstetric anesthetists who advocates its use for labor analgesia with a bolus dose of 20 to 40 mcg and a 2-minute lockup. Associated problems for this indication include sedation and maternal desaturation. Hypothermia may reduce Remifentanil clearance by up to 20%. There is a potential to cause post-operative opioid-induced hyperalgesia. OIH can be reduced by low-dose ketamine, suggesting that it is mediated by NMDA receptor activation. Acute opioid tolerance can occur with Remifentanil. Other adverse effects of Remifentanil includes muscle rigidity, bradycardia, mild decreases in systemic blood pressure, depression of ventilation, nausea and vomiting. Depression of ventilation can occur if any Remifentanil is left in the dead space of IV lines and subsequently flushed with other drugs or fluids. These are my references. Thank you.